Pneumococcal disease and vaccination. Dr. Jalal Mohsin Uddin, DTCD, FCPS Pulmonology. Assistant Professor, NIDCH Contents. Burden of pneumococcal disease in adults. Risk factors for pneumococcal disease in adults. Why adult vaccination pneumococcal conjugate vaccine in adults. Evolution of guidelines for pneumococcal vaccines in adults. Steps to improve adult vaccination coverage in clinical practice. Summary and take-home message. Introduction. Pneumococcal disease (PD) is caused by a bacterium called Streptococcus pneumonia, which is also known as pneumococcus. There are more than 90 serotypes of this bacterium. Introduction. Continue. Pneumococcal infection is a major cause of morbidity and mortality worldwide. There are invasive and non-invasive pneumococcal diseases. There are wide range of infections caused by Streptococcus pneumoniae, ear infections, sinus infections, pneumonia, bacteremia, meningitis, sepsis. Who are at risk of developing pneumococcal disease? Although anyone can get pneumococcal disease, those at particularly high risk are infants and young children. Adults who are 65 and older and individuals with chronic medical illnesses or weakened immune systems include smoking, alcoholism, chronic heart, kidney, liver, or lung disease. Who are at risk of developing pneumococcal disease? Continue. Cerebrospinal fluid leak, cochlear implant, diabetes, HIV infection, cancer, solid organ transplant, taking medicine that weakens the immune system, nephrotic syndrome, sickle cell disease, damaged spleen, or no spleen. Certain chronic medical conditions can increase the risk of pneumococcal pneumonia in adults. Incidence of pneumococcal pneumonia from a population-based prospective cohort study. In adults greater than or equal to 50 years of age, N equals 2,025,730 in Catalonia, Spain, 2015, by select risk conditions. Comorbidities in patients of community-acquired pneumonia. The most prevalent comorbidities are chronic obstructive pulmonary disease 16.4%, 34.2%. Hypertension 13.6%, 38.1%. Diabetes mellitus 9.9%, 24.7%. Age. Male gender COPD chronic alcohol use. Smoking. Upper respiratory tract infections congestive heart failure. Immunodeficiency cerebrovascular disease liver disease. Diabetes mellitus. Chronic renal failure. Malignancy. Corticosteroid therapy. Global burden of pneumococcal disease in adult patients. The burden of non-invasive pneumococcal disease in adults is mainly determined by community-acquired pneumonia. Within the cluster of invasive pneumococcal diseases, pneumonia also represents the most common infectious source. Global burden of pneumococcal disease in adult patients. Continue. Prospective 15-year surveillance of invasive bacterial infections in India showed pneumoniae infection in 43.3% of subjects, with case fatality rates from 25 to 30% across adult age groups. The etiology of CAP in adults in India, pneumoniae is the most common identified pathogen. Why it is important to consider pneumococcal vaccination for elderly. Data from US shows, about 1 in 20 individuals who get pneumococcal pneumonia will die. The death rate is higher among adults aged 65 years and older. Pneumococcal meningitis can be deadly. People who survive pneumococcal meningitis can suffer from devastating health problems like hearing loss, seizures, blindness, and paralysis. Why it is important to consider pneumococcal vaccination for elderly. Continue. Pneumococcal bloodstream infections can be deadly. Treatment requires hospitalization, and patients often need weeks or months before returning to normal activities. Why it is important to consider pneumococcal vaccination for elderly. Continue. The graph shows the rate of IPD, including pneumonia with bacteremia, meningitis, and bacteremia, per 100,000 adults aged 18 years and older in the US during 2017. The rate increases from 2.5 per 100,000 population among adults aged 18 to 34 years, to 41.8 among those aged greater than or equal to 85 years, nearly a 17-fold increase. Why it is important to consider pneumococcal vaccination for elderly. Continue. In elderly individuals, age-related decline in immune function leads to greater susceptibility to infections, which includes decreased efficiency of the adaptive immune system, reduced rates of B and T cell production, reduced antibody production, increased number of dysfunctional memory cells, and decreased lymphopoiesis. Understanding risk stacking. Presence of multiple, concomitant risk factors. Risk stacking increases the likelihood of developing pneumococcal disease beyond the risk posed by individual risk factors alone. The presence of multiple chronic medical conditions can further increase the risk of pneumonia in adults. Rates of all-cause pneumonia among adults greater than or equal to 18 years of age. By number of comorbidities, Germany, 2009 to 2012. The risk of invasive pneumococcal disease is increased in adults with certain comorbid conditions. Data from a study from the National Dataset of Laboratory-confirmed invasive pneumococcal diseases in England and Wales, 2002 to 2009. Here is the estimated annual incidence of invasive pneumococcal diseases per 100,000 persons. Community-acquired pneumonia burden in India. A study of community-acquired pneumonias in elderly individuals in Bijapur, India. Community-acquired pneumonia in elderly has different clinical presentation and higher mortality than CAP in other age group. A total of 50 patients were studied, aged 66 to 88 years. Most common organisms responsible was Streptococcus pneumonia. Mortality was 16%. Mortality rates for elderly patients hospitalized with CAP in previous reports range from 6 to 40%. Pneumoniae is the most common cause of community-acquired pneumonia in older adults above 60 years. Community-acquired pneumonia burden in India. Continue. Community-acquired pneumonia burden in India. Continue. Microbial etiology in hospitalized North Indian adults with community-acquired pneumonia. The study was conducted in a 700-bedded North Indian hospital. Consecutive adults admitted with CAP over a period of 2 years from 2013 to 2015 were recruited for the study. 32% of all cases were on account of Streptococcus pneumonia. Etiology of pneumonia in elderly above 60 years of age. Etiology: Streptococcus pneumoniae, Legionella pneumophila, Mycoplasma pneumonia, Chlamydia pneumoniae, Klebsiella species, Pseudomonas species, MSSA, MRSA, Mycobacterium tuberculosis, Influenza, Acinetobacter species, Staphylococcus hemolyticus. No pathogen found. The consequences of CAP in adults can be severe. In a U.S. prospective, population-based, cohort study among adults 18+ years of age hospitalized for CAP in Louisville, existing health conditions can be worsened by pneumonia. Health condition: reported worsening % days until return to baseline. Asthma, 23.024.8. COPD 24.452.4. Chronic bronchitis 12.232.8. Chronic emphysema 8.660.0. High blood pressure 20.121.6. Heart disease 5.938.7. Diabetes 9.818.0. Other 8.548.3. Hospitalization for CAP increases the risk of cardiovascular disease CVD events in adults. Risk of CVD is elevated following pneumonia or sepsis for several years in adults aged greater than or equal to 18 years in Sweden. 1969 to 2010 revealed that admission for serious infection, sepsis or pneumonia, the risk of CVD remained high for over 5 years after the infection, with the highest risks noted during the first 3 years since infection. Here hazard ratio HR is shown. Pneumococcal pneumonia has been associated with reduced long-term survival. Kaplan-Meier plots show the cumulative 10-year survival of 344 patients who survived pneumococcal pneumonia compared with the expected 10-year survival of an average 63-year-old American male. Pneumococcal vaccines for adults. Currently, 2 types of vaccines are accessible for adult use, including a 23-valent pneumococcal polysaccharide vaccine PPV-23, comprising capsular antigens of 23 pneumococcal serotypes. It has been used in adults for nearly 30 years. A 13-valent pneumococcal conjugate vaccine PCV-13, containing capsular polysaccharide antigens of 13 pneumococcal serotypes, independently conjugated to a protein carrier. Polysaccharide vaccine and conjugate vaccine. Polysaccharide vaccine contain polysaccharide antigens. Stimulate B cells to produce antibodies. T cell, independent immune response that cannot be boosted. Conjugate vaccine contain polysaccharide antigens covalently linked to a carrier protein. Stimulate T cells to help B cells produce antibodies and generate immune memory. T cell dependent immune response and booster response with revaccination. Characteristics of pneumococcal vaccines. Characteristics: type of vaccine. PPSV-23. Unconjugated capsular polysaccharide antigens. Contains antigens from 23 common serotypes 1, 2, 3, 4, 5, 6b, 7f, 8, 9n, 9v, 10a, 11a, 12f, 14, 15b, 17f, 18c, 19a, 19f, 20, 22f, 23f, and 33f. Immune response: T cell independent immune response IgM antibody produced, response declines in 3 to 5 years, and no anamnestic response at revaccination. Efficacy. Considerable efficacy proven against IPD 50%-70% in immunocompetent elderly individuals. Unclear null to small efficacy against non-bacteremic pneumococcal pneumonia. No efficacy demonstrated in reducing nasopharyngeal carriage. No impact proved in reducing the overall pneumococcal disease burden. PCV-13. Capsular polysaccharides conjugated with a protein carrier contains antigens from 13 common serotypes: serotypes 1, 3, 4, 5, 6a, 6b, 7f, 9v, 14, 18c, 19a, 19f, and 23f. T cell dependent immune response: larger duration and boosting effect at revaccination. High efficacy 80%-90% against vaccine type IPD proven in children. At present, relatively small serotype coverage for IPD in the elderly 30%-40%. Potential efficacy in reducing nasopharyngeal carriage. Future reduction of vaccination impact in adults elderly because of indirect effects from the pediatric use of PCV13. IPD, invasive pneumococcal disease, IgM, immunoglobulin M, PPSV23, 23-valent pneumococcal polysaccharide vaccine, PCV13, 13-valent pneumococcal conjugate vaccine. Characteristics of PCV13. A total of 7 European and US studies assessed the safety of Prevnar 13 in 48,806 adults aged 18 to 101 years, including those with risk conditions. Immunogenicity, immune responses to PCV13 were non-inferior to those elicited by PPV23. Efficacy, statistically significant reductions in first episode of vaccine type CAP and IPD with PCV13 in adults 65 and older. Safety, the safety profile of PCV13 was consistent across all populations, including those who were previously vaccinated with PPV23. Characteristics of PCV13 continue. Sequencing, PCV13 enhances the immune response to a subsequent dose of PPV23 vs PPV23 alone. Co-administration, studies with influenza support co-administration with Prevnar 13 in adults. High-risk populations PCV13 elicits an immune response in HIV-infected individuals. In patients with hematopoietic stem cell transplant, PCV13 elicited higher immune responses for all vaccine serotypes than baseline. Each subsequent dose resulted in increased immunogenicity. PCV13 demonstrated efficacy against a first episode of vaccine type CAP in adults aged 65 years and older. Prevention of a first episode of vaccine type CAP, 46%. Prevention of a first episode of vaccine type non-bacteremic. Non-invasive CAP, 45%. Prevention of a first episode of vaccine type invasive pneumococcal disease 75%. Structure of PCV13. PCV13 includes capsular polysaccharide of 13 serotypes of Streptococcus pneumoniae conjugated to a protein carrier CRM. Conjugation allows for stimulation of the T-cell dependent immune response necessary for immune memory. PCV13 provides protection against pneumococcal pneumonia and IPD. Intervals between PCV13 and PPSV23 vaccines, recommendations of the Advisory Committee on Immunization Practices. Pneumococcal vaccine naive persons aged greater than or equal to 65 years. PCV13 at age greater than or equal to 65 years. PPSV23. Greater than or equal to 1 year. Persons who previously received PPSV23 at age greater than or equal to 65 years. PPSV23 already received. At age greater than or equal to 65 years. PCV13. Greater than or equal to 1 year. Persons who previously received PPSV23 before age 65 years who are now aged greater than or equal to 65 years. PPSV23 already received. At age greater than or equal to 65 years. PCV13 at age greater than or equal to 65 years. PPSV23. Greater than or equal to 1 year. Greater than or equal to 1 year. Greater than or equal to 5 years. Sequencing pneumococcal vaccine for adults in clinical practice. Adherence to vaccination schedules is critical for providing maximum effectiveness against vaccine-preventable diseases. No history of pneumococcal vaccine 2. First 3. Followed by PCV 1300. Patients who have already received a dose of polysaccharide vaccine PPSV23 4. For immunocompromised and immunocompetent patients with chronic conditions and no history of pneumococcal vaccination 3. PPSV23. First 3. PPSV23. Followed by 1 year. PCV13. First 3. Followed by PCV13 28 weeks. PPSV23. Sequencing pneumococcal vaccine for adults in your practice continue. Influenza and pneumococcal vaccination co-administration 3,5. These vaccines can be co-administered. Influenza vaccine. PCV13. Guidelines on COVID-19 and any other type of vaccination. COVID-19 vaccine. 14 days gap. Any other vaccine. Burden of co-infection with influenza and Streptococcus pneumoniae. Pneumoniae has consistently been one of the most frequent cause of influenza-related bacterial pneumonia. Secondary bacterial infection in adults with influenza is a major cause of morbidity and mortality. Pneumoniae is one of the most common co-infecting pathogens detected in hospitalized patients with influenza. Pneumoniae. S. aureus. S. pyogenes. P. aeruginosa. Other. Vaccinating against influenza may create an opportunity to also vaccinate appropriate adults with PCV13. PCV13 may be concomitantly administered with seasonal influenza vaccine. The immune response to PCV13 in adults aged 50 years and older when given with influenza vaccine was non-inferior compared with PCV13 administered alone. Vaccinating against influenza may create an opportunity to also vaccinate appropriate adults with PCV13 continue. When PCV13 is administered at the same time as another injectable vaccine the vaccines should always be administered at different injection sites. Incorporating vaccination as a part of patient management. For all healthcare professionals, whether they provide vaccinations or not, to take steps to help ensure that their adult patients are fully immunized. Assess. Assess the vaccination status of patients at every clinical encounter. Recommend. Strongly recommend needed vaccines. Document. Document vaccinations. Administer. Refer. Offer the vaccines you stock. Refer patients to providers in the area that offer vaccines that you don't stock. You can make a difference. Patients trust you to give them the best advice on how to protect their health. Vaccine-preventable diseases can result in serious illness, hospitalization, and even death. Make adult vaccination a standard of care in your practice. Thank you. Pneumococcal disease and vaccination. Learning Pulmonology.